Hi, everyone. Thank you for joining us. I don't think there's really anybody on yet, but Monica and I are here waiting for you. So if you're on, wonderful. And if you're not, then we'll wait for you. Oh, yes, they are. I can see how many are signing on. So this is great. We're going to give it a few minutes and get some more people signed on. We're going to wait for a couple more people.
I'll respond to Nancy.
Right. Okay.
That's okay, Nancy. If you can hear me, this is Monica.
And this is Marcia. We just had one person who was signed on, but his internet's been out all afternoon, so he's not going to be able to join us. I don't know if I kept worrying that the weather was going to be an issue because I have my flashlight right over here and we'll keep our fingers crossed. So we don't want to lose everything. But it's a miserable night out there. I hope everybody's home. All right, we're going to start now. I'm Marcia Hilditch, for those of you that don't know that, and I am the Senior Community Outreach Manager for the National Kidney Foundation in Connecticut. I've been with the NKF for 24 years, and this program that we're doing, these patient programs that we've been doing, is something new to Connecticut. And I think it's become one of my favorite things, especially this one, because I got to talk to so many of you and heard your stories and your concerns, which is why we do this, because so many people have concerns and there's just so much to know when you're waiting for a transplant. So I'm very excited to welcome you all this evening. We're going to have a question and answer period at the end of Monica's slides. So if you will put your questions in the chat box, it looks like we have a lot of comments already, 5. And then either Monica or I read the questions and she will answer them. I do want to say, please keep you're all welcome to, I want you to ask questions, but in fairness to everyone else who is on the call, because there's over 20 people on the call, I want to make sure that everybody has a chance, and we have to end this at 6 o'clock. So, you know where to get Monica if you need to, and you know how to get a hold of me if you have any questions afterwards. This is also being recorded. So if anybody wants the recording, please let me know. So is that, oh, nope, that's it. At this time, I would like to introduce Monica Pendleton, Monica is a kidney transplant coordinator and a good friend of mine, and I've had lots of fun working with her putting this program together. Monica?
Thank you, Marcia. So for those of you who don't know me, like Marcia said, I'm a transplant coordinator. I've been in this role for 7.5 years. And prior to that, I was in California working on the floor with transplant patients. So obviously transplant is my passion, and I think I will do this until I retire. And I've been helping out with MKF because it's a great organization and they offer so much information out. So I'm going to share my screen. And if you have questions, go ahead and put them in even in the while I'm talking, and I can always stop and answer or wait to the end. This is going to be, it's informal in the fact that it's a bunch of basic information that I have noticed over my years as being a transplant coordinator that we tell patients, but we give them so much information. A lot of the important stuff can be missed just because we do give you so much information. So this is primarily directed for while you're waiting for a kidney transplant. So starting at the basics, for renal disease, it starts off as CKD, which is chronic kidney disease, and eventually that progresses into end-stage renal disease. So if you're not yet on dialysis, your doctor might say you're stage 3 or you're stage 4. Most people start talking about dialysis when they're stage 5 with their nephrologist. Some people will still have a high GFR. That's how they measure your renal failure. And the GFR is just a lab term to see how much your glomerular filtration rate is, which is just the tubes in your kidneys that filter everything out. And as that number comes down, your kidney disease increases. Each person responds differently to the toxins as they build up in your blood. So you could be stage 5 with a GFR of 15 and you might be doing phenomenal, don't even notice it. Other people I know, they've started dialysis when their GFR is at 15. So these are the basic stages. Once a person's GFR lab value hits 20, you can be and should be referred to a transplant center for consideration of workup. Because even though you're not yet on dialysis, if your GFR is 20 or below, we could actually list you if you qualify and you can start accruing wait time. So that when your kidney does get to that point of needing dialysis or a transplant, if you have a living donor, you'll have already accrued the wait time. So that's always very helpful. And I try to share that with everyone. If you know people who have renal disease and are not yet being referred to a transplant center, ask what the labs are, and that key number is your GFR lab value of 20. So the wait time, I get this all the time. The average wait time, what's average wait time? On a basic scale, in the O blood group, it can be like 7 to 9 years. Now, 7 years ago when I started, it was about 5 years. But as people live longer, kidney disease goes up, the wait time gets longer because more people are going on the wait list. And O being the most common blood group, hence why it's longer. The B blood group is between, I don't know if my face is covering it up, so let me move my little thing over here. The B blood group is about 8 years, but this varies greatly. Again, there's multiple reasons we'll get into, and this is just a basic average. The A blood group is about 5 to 6 years, and the AB blood group, which is the rarest blood group, so there's less people that can receive more offers, is about 3 to 4 years. Again, 7 years ago when I started, it was about 1 to 2 years in the AB blood group. So I've noticed a significant increase in wait time, and patients sometimes can't understand that because when you come in, we'll give you an average, and that can get longer or it can get shorter depending on various different things. But this is the average as of right now. And as I said, these are simply estimates, the best guess. The offers that we use, they come primarily from our region, which is up and down the East Coast. However, we do get offers if you are in the computer and your blood makeup is a perfect match with someone who happens to be, let's say in California, you would come up as a perfect match. And it's like winning the golden ticket. And you would, even though you might have 5 years of wait time, you need to wait, you at any time could come up for these offers. I've only seen this maybe half a dozen times in the last 7 years. There is a new allocation process, which is just how we dole out the kidneys, how we decide who gets first opportunity. That helps lower, it helps lower the playing field, basically. Years ago, people who were on dialysis were not being referred for transplant. So therefore, they weren't getting the wait time. So when they were referred, they were told they had to wait 5 or 6 years, but they'd already been on dialysis, possibly up to 6 years, and they weren't given credit for that. So we changed the laws where they can get back credit. And the reason why we did that is because we know hemodialysis can save your life, but also can shorten your life expectancy. Transplant is to hopefully get you a better quality of life and live longer. So we did that. And currently now we've also changed it again to where we're now not so much going just in our region, we're going distant from the kidney offer. So that before, our region from Maine down to the border of New York used to be primarily where we get our offers. Now it's within a 250-mile radius from where the organ offer is. How that helps is most of our kidneys before were coming from Maine, where there were a lot of drug use. And unfortunately, there's a lot of deceased donors due to drug overdose. That's a 5-hour drive away. Where if you look at Philadelphia, which is 3 hours, New York, 2 hours in any direction, we're now seeing a lot more offers, even from New Jersey. So we have access to those, which we're hoping is going to lower the wait time for people across the board. There are different types of offers that can shorten the wait time. There's something called a PHS, Public Health Service screening, where patients who have had IV drug use or risky sexual behavior or jail time where they could have been exposed to TB. These are considered increased risk. However, the chance of getting something from these offers is less than 1%. For those who are on hemodialysis, there's a less than 1% chance you could get something from the hemodialysis machine, even though they sterilize them, because you can't guarantee complete cleaning. However, I haven't met anyone who's gotten something from them, but it tends to scare people when they see this PHS. The HCV is hepatitis C virus. So many people have had hepatitis C in the past, and recently we've been able to cure it. So all those people who have been exposed to hepatitis C and or gotten it, they've either been treated and they cleared it, or their body cleared it, or they just have a memory cell. Well, prior to us using these organ offers, anyone who died who had a history of hepatitis, we would throw those kidneys away. Now we realize when we test these organs, what we do is we test to see, have they ever had hepatitis C? If that first one comes back yes, then we do a second test. Do they currently have it at the time of death? If that comes back no, we can use these kidneys in anybody. Hepatitis affects the liver. However, these kidneys don't actually have active hepatitis. So this is something new we've started to do. We are moving towards putting hepatitis C kidneys who have hepatitis at the time of death into people who don't have it and treating them to cure it afterwards. We're not there yet for kidneys. We are doing it for liver, and other centers are doing it for kidneys, like down in Florida and I believe up in Massachusetts. So this also opens up a wide pool of potential kidneys. And also the high KDPI. I hear a lot of feedback from people saying, my nephrologist said, don't take a high KDPI. What this KDPI means is it's a kidney donor profile index. Basically, this was designed so that we don't put a 65-year-old kidney into a 20-year-old person. But the same thing, though, if a 65-year-old person needs a kidney and the next person that happens to pass is a 26-year-old, they will get it. We want the kidney to hopefully outlive the person we put it in, meaning we don't want the kidney to fail while you're still alive. We'd like this kidney to work longer. So this has helped to try to screen that out. The top 2 reasons for kidney disease are diabetes and high blood pressure. In a living person, we know if we're diabetic, what our A1C is. Are we taking our medication? Are we eating right? High blood pressure. We know if we're on medication. We know how long we're on it. We know if we're compliant. Unfortunately, in the people who pass, we don't know. So therefore, if a person dies, we get their KDPI number is based on what the cause of death was. It's also based on their age. It's also based on if they're diabetic or high blood pressure. The more things they have, the higher the number goes, which means the less life of the kidney is left over. So a lot of people say, I don't want a high KDPI over 85% because that kidney is not good. This isn't true because we don't know if they took their medications, or we don't know if they were even on medications. Were they pre-diabetic? Were they pre-high blood pressure? So our surgeons will look at these kidneys and the person's general health. And if it's a high KDPI and they feel it could be a good kidney, our surgeons will do a biopsy of that kidney and look at it under a microscope to see, is that kidney age that of a typical 61-year-old? Or is that kidney age that of a 61-year-old who has high blood pressure, who never took her medication because there's advanced hardening of the cells? And our surgeons look at that and they determine, is this a good kidney or not? And they will also put it on a pump to see how it functions. So there's a lot of ways for our surgeons to determine if in fact these are good kidneys. You might get called in for a kidney. You might be in the operating room waiting to be put under, and then the kidney comes and our surgeons might look at something at the last minute, say, hey, after further closer look, we're not going to use this kidney. So these things all open up different opportunities, but you have to understand them to be able to accept them. And I always tell people, until you wake up with a kidney in you, anything can happen from point A to point B. We have no control over most of that other than accepting it and then hopefully getting it and putting it in you. Other things that can shorten or lengthen the time is the need versus the quality of the organs. As I said, people live older, kidneys are used more. I like to say to my older population, if we get a 65-year-old kidney and you're 70, or in your 60s or 70s, you don't need a kidney that hopefully will last 25, 30 years, as opposed to a 30-year-old. We're not going to put a 65-year-old kidney in a 30-year-old. But if you're in your 60s or even 70s, we're going to look at those 60-year-old kidneys because we want to keep you off dialysis if you're not on it yet, or if we can get you off dialysis. So we look at each kidney separately, and it also, the quality and the quantity varies greatly from month to month of how many offers we get. We can get 100 offers a month and might only say yes to 30 because they're not good kidneys. There's also always living donors, which are always the best opportunity because it's coming from a live person into a live person. Living donor kidney transplants work faster and tend to last longer. And you don't need, as a recipient, to know your blood type, which I could always tell at anyone at any time. You just need to give them the phone number and let us do the screening. If they're not a match for you, they can go into something called a swap, where someone else might have a donor, but they're not compatible with them, but they'd be willing to donate to someone else so that their loved one can get a kidney. These swaps are phenomenal. I've been involved in many swaps, both in California and here. And then about 2 years ago, we started doing something else, which we call an A to B. So to make it simple, usually you get an organ like your blood type. Blood type B is the longest organ offer. When we check your blood, we know what your blood type is. You're either A or B or O. But we also look to see what your blood is made up of. And that is critical with these A to B offers. So if you're a blood type B, we know what your blood is made up of. And your blood has red blood cells and white blood cells. And the red blood cells have these little things on them called antigens. And so do the white blood cells. The red blood cells, they just carry oxygen to your organs. We're not concerned so much about that in transplant. With the white blood cells, these little antigens are what we suppress during transplant so that you don't reject a kidney. We have known through years of research and studies, and we've been doing it for a couple of years, that a blood type B person, if their antigens, which are like a bingo card, A1, A2, B5, that's how they label them, if they have the right antigens in their blood and they don't have other predisposed factors, they can technically get a blood type A organ offer. Well, as you look back a few slides, blood type A wait time is much shorter. And if you qualify for one of these A to B offers, there could be 100 people in the blood group A waiting for a kidney. However, because you're going to be a better match for them genetically, you would actually trump them and go above them, even if you don't have as much wait time, because you would be a better match, less chance of rejection. This is another way to cut wait time. And then, as I said before, each organ offer is the best fit with the best recipient at the time of the offer. So it's not just a generic, oh, you're next on the list, you get the next kidney. There's so many other factors. Other things while you're waiting for a kidney, and some of you on here might be chuckling at me because we've had discussions about your monthly lab draw. If you're not yet on dialysis, it's the patient's responsibility to go to the lab every month, and we can send them kits. They get a little tube of red blood that gets sent to us. That's so that in the event of an organ offer, we have a current blood sample to match with the potential donor. Once you transition to dialysis, it's about a 60-day lapse. Unless someone tells us, hey, I'm on dialysis, then we can call the dialysis unit and say, hey, we need blood samples every month. And then it takes probably about 60 days also to get the legal form. We call it a 2728 that just shows when you started dialysis. And once you start dialysis, they will send it to us every month. But in the beginning, there can be some overlap. But if you hear from us saying we don't have a monthly red top, it's usually when someone transitions or they're not yet on dialysis and they might not have been aware that we need it monthly to stay active. While you wait, if you're have an emergency room visit, if you're in the hospital, whether it be Yale or outside of Yale, it's your responsibility to let me, a coordinator, know, because if it's at Yale and someone says, hey, Monica, I was in the hospital, I can go in your chart and look. However, if I'm not notified, I might not know to go in. And then once I go in, I can see it. Or if it's an outside hospital, I might never know. You cannot be active on the wait list if you're in the hospital, if you have an open wound infection. Because if you're transplanted, we put you on immunosuppressants, the medicines that help you not reject the kidney. And when you're on that, wound healing is slower. Infections can spread. So we need to be notified of any ED visits just to make sure everything's okay. Blood transfusions. A lot of people don't realize when you receive a blood transfusion, this is when your body can react to it by making antibodies against it. I had mentioned that our blood is made up and we know what your antigens are. So if you're a woman and you get pregnant, when you're exposed to the other person's blood makeup during the pregnancy, your body can say, I'll make a baby, but I don't like what their antigens are, and they can make antibodies against them, which means if a mom who had children needs a kidney, her husband might not be able to donate to her because she had made antibodies against his antigens. If it sounds confusing, we can talk anytime, but the bottom line is anytime you're exposed to any blood product, blood transfusion, pregnancy, whether the pregnancy is capped or terminated or lost, or if you've had a prior transplant, we can see that. You need to let the coordinator know, because if you had a blood transfusion 2 weeks ago, and let's say we didn't know, and then you come up for an organ offer today, and we do a cross match, which means mix your blood with the donor's blood, it might say everything's okay, but your body could be developing these antibodies against certain genetic antigens in the donor, which means you could reject that kidney regardless of what we do. And we don't want that for anybody. It just makes things much harder to find a match. I already talked about open wounds, diabetics. It's important to check your feet, infections, boils, dental work. More insurance companies are saying we need dental clearance before we can authorize them for transplant. Just be aware of that. Boils. I can't tell you how many times people will take a picture, send it to me and say, do I need to be concerned? And then I can review it with my surgeon. And if the surgeon says, oh, just make them temporarily inactive, put them on hold, they need to be on antibiotics for 7 days, because even though it might be a little boil infection, if you were to get transplanted, that thing can tunnel and get into your bloodstream, and that's not good. I already talked about dental. Standard of care testing. Everyone should have a primary care doctor. Everyone's going to need a colonoscopy once you hit a certain age. They've made it up to 45 from 50. These are things that people should be doing regardless of transplant or not. In regards to transplant, we're going to make sure the colonoscopy is done. We're going to make sure you're going to have make sure your mammogram is updated. If it applies a pap smear, cardiac testing. Once you're at the age of 50 and you're on dialysis and you need a kidney transplant, you really need a cardiologist. And you should see him at least once every 2 years, because we do require cardiac testing of a stress test and an echo. And we don't like them to be over 2 years. This can fluctuate. If you're a long-term diabetic, we're probably going to want a cardiac cath, which is just a test where they go in and look at the vessels around your heart, because diabetics can build up a lot of plaque that, faster than other people. So if you don't have a primary care doctor, you need to get one. And if you don't have a cardiologist, your primary care doctor can refer you to one, or your nephrologist. Our dialysis units are wonderful, and those nephrologists have been taking on so much of doing things out of their area, just out of the generosity of them, because they want to see you succeed. However, they have other things they need to focus in on. So we really try to stress, get a primary care doctor if you don't have one, and make sure that all your standard care of testing is up to date. And again, communication with the transplant team, any changes in your health, any open wounds, any infections. I always tell people, leave me a voicemail. It's private voicemail. And then let us decide if we need to put you temporarily on hold, or if it's okay to just keep going. Now, that temporarily on hold takes us to the active and inactive. Unfortunately, sometimes people think when I say I have to make you temporarily inactive, they think I'm taking them off the transplant list. I'm not. I'm not that mean. It just means for your safety, we're going to hold off on having you eligible for organ offers while the wounds heal, until we can get the testing. You're still accruing wait time. You're still on the list. We just have a block so that you don't get a call in the middle of the night saying, how's your health? You came up for an organ offer, only to be let down. And again, it's for safety. If you did have an open wound and you come in for a transplant, and it's happened, we will find that wound, because we check it top to bottom to make sure, for safety reasons, it's for your own safety. And we look extra close at your cardiac testing, because cardiac might say you're okay for transplant, which might be thought of as a minor surgery, but transplant is a huge surgery where you get large volumes of fluid, possibly up to 8 liters of fluid during a transplant. And if your heart's not strong enough to filter that blood through and do the shifts, it's not going to be a good outcome for you. So we look very closely, and we do tests to make sure that your heart's strong enough for you to undergo. We're not trying to put you off, or we don't get any kickbacks from it. It's for your safety. Some of the reasons we make you inactive were in the prior scale, or I'm sorry, slide: infection, open wounds, etc. And when you're active, you're eligible for organ offers at any time. When you're inactive, like I said, you're still on the list, you're just holding off on organ offers. If you were to be removed, it would say you are removed, that word. And as I mentioned, the reasons for the inactive status, there's many reasons. If we can't get a hold of you, I'm going to have to make you temporarily inactive until someone calls me back. If you're going on vacation, please let me know how long you're going to be gone, how far you're going to be, and if you would be able to return at a moment's notice. Many people say, hey, Monica, I'm going to go to Spain for a month. I'll be back. Great, call me when you're back. Just click a button, they click and they come back. It's not a problem, but we can't have you active if you're out of the country, or if you're out of reach, we can't reach you and you can't come back right away. Some organ offers, we might call and say, this is just an early preliminary organ offer. Others might say, can you come in now? Others say, I'll get back to you, and you might not get called back for 2 days. Each offer is different. There's no way we can foresee how quick they're going to come in or what time of day or night. A lot of these offers can come at 3 o'clock in the morning. Trust me, I've been on that. So just while you're active, we need to be able to reach you at all times. If you are inactive, there's steps that you need to make so that you can be made active again. One of them is, let's say I need a mammogram from someone. They have a history of breast cancer. They get the mammogram, but if they don't tell me that they got it, and if it's not done at Yale, I don't know. So if someone doesn't call and say, hey, I got it, did you get it? Or let us know, we won't know. The blood, we have to get blood before we make you active. If something needs to be resolved, the communication needs to be to us that it's been done. I always tell my people, get a folder. Anytime you have a test done outside of the system or even inside the system, ask for a copy of it. That way, if you say, hey, Monica, I had a test done here, I can get a copy of it. And if for some reason they're not sending it to me, you can send it to me. And that way we always have everything up to date. And again, when you're made inactive, I'm not removing you. I would specifically say you're being removed, but it would be a discussion beforehand. We always talk to people before we do that. And this is just reiterating the reasons for being made inactive on the list. I've had someone say, well, what does a broken leg have to do with a kidney transplant? And it goes back to the healing and the immunosuppressants. Dental concerns. I've had people say, what does a dental infection? I have seen, unfortunately, several people who've had dental infections and it gets into their bloodstream and you can develop what's called endocarditis. You get vegetation growth on your heart. And that can come, and a lot of times does come from a dental infection where that goes into the bloodstream and it hops onto the heart. It can be deadly. So, if we're going to put you on immunosuppressants, we want to make sure you don't have any infections brewing, in your teeth. And unfortunately, people need to get, teeth pulled a lot of times prior. Hospitalizations, new cardiac findings. I've gotten really good at looking at cardiac testing, and I can explain if you need something further and why, but again, it's for your safety. We look at these tests probably closer than most people because we know what a transplant involves. I also go through your labs very closely. Your PTH is your parathyroid hormone. Those who are on dialysis know that your dialysis units check this. Because with renal failure, this number can go up, and as the number goes up, it can do damage to your bones and other issues. So we like it at a lower level. And they usually put you on medication at the dialysis units. So I check these, and I might have to call and say, I need to put you on hold until that number comes down. On PSAs, just because let's say you have prostate cancer, doesn't necessarily mean you're off the list. Cancers depends on what type they are, where they are, how they're treated. So we look very closely at your PSAs as well as your mammograms and your history. And it's critical that these are done on a regular basis because we don't want something to flare up that we don't know about. And as I mentioned, traveling out of the country, just keep close contact with your coordinator. We like that. So that's pretty much all I have as far as my spiel while waiting. I'm sure there's questions out there.
I haven't seen it since we began show chat reviews. Oh, here we go. A couple of people just, said, and one person said, finally, I can put a face to the name Monica.
Oh, yes. Hi, Nancy.
And I share my link with my daughter. Of course you can. And somebody who couldn't get the picture. Come on, get out of there. So get out of there. Be right back. Sorry.
You explain the swap programs
and
in terms of.
Yeah, go ahead.
So I work with a coworker. Her name is Grace, and she deals with all the people with the swap as well as with the living donors. So there's two different swaps. There's an internal one. There's a national registry to where people can sign up, and Grace goes over all the details. And a lot of that comes from, unfortunately, I've met people who have someone who wants to be a living donor, but they only want to give their kidney to this person. And if they're not willing to give to someone else who might have someone, they can't go into a swap. If I wanted to give my kidney to Marcia and I wasn't a match, they would ask me, would you be willing to go into a swap? And I could either say, absolutely, because if I give to so-and-so, they might give to Marcia. But people a lot of times say, no, I only want to give to my loved one. So the swap, they put it in, it's a big computer and it works from coast to coast. My friends in California know my colleagues here in Connecticut because everyone goes in it. So that way we can find a swap to where if we put a kidney in someone here and then our donor here might be flown to Philadelphia for someone in Philadelphia, and then that one might go. So it can literally go cross country in the swap. And I hope that helps make some sense.
If someone is brain dead, is that considered a living donor?
No, great question. And where this is coming from, I'm assuming, and you can correct me if I'm wrong, that's a phenomenal question because it's good. There's two types of deceased donors. There's brain dead and there's DCD, which means donation after cardiac death. And then there's living donors, someone who's living and breathing. Where the confusion is if they're brain dead, they're dead. We're keeping the fluid going through their body on a ventilator and with medication, and they're on the vent. The brain isn't working, and if we shut that off, no oxygen goes anywhere. So we can plan accordingly to take the organs out for allocation to transplant. And a deceased DCD, donation after cardiac death, that person's heart still has some function. The probability of them surviving if we turn off the vent and the medication is so high that they wouldn't progress. The family has agreed to donate their organs. In this situation, they plan a time with the family's okay of the deceased person to turn everything off, and that heart stops beating. Once it stops beating, then they can cut the person and take the organs out. But the heart has to stop beating completely within 45 minutes in order to use those organs. And I say that because a normal heart rate is 60 beats to 100 beats a minute. Athletes have a heart rate where the heart beats 50, 40, or 50 beats a minute. No one can survive if a heart's only beating 20 beats a minute or 10 beats a minute or even 5 beats a minute. But we can't cut on a person even at that, even though they're not surviving. No one would survive. And what happens is every organ in the body is in a warm environment and the decay breaks down because we can't take them out and put them on ice and there's not enough blood going through. So to answer the question, no, they are not, and that is why.
Wait a minute. I am currently at 22 EGFR. Does that mean I am inactive and not accruing time?
Okay, no, Nancy. So if you're on the list, you're on the list, you're accruing wait time, whether you're active or inactive. With an EGFR of 22 means you still have a good amount of kidney function, not enough to, run marathons, but it's going to progressively go down. If you were to get the flu, God forbid, and you get diarrhea or vomiting, you get dehydrated, dehydration can really hurt the kidneys quick, and that number might drop suddenly and you might start dialysis. Once you're placed on the list, whether active or inactive, you are accruing wait time, regardless if you're active or inactive.
Okay.
And how long is a kidney viable for once it's removed for transplant? God, these people have great questions.
Yes.
So it varies depending on how old the donor is, how cause of death before they were able to get to that person. So if someone's in a motor vehicle accident and it takes some time to cut them out, it's going to take that much time before we can start perfusing the organs to get blood to them. We have transplanted. A lot of people say no to these kidneys that come out of people and they've been sitting on ice for hours. Some people say they're not good. They're called delayed graft function kidneys, DGF for short. I've seen our surgeons put a kidney in someone that had almost 30 hours of sitting on ice. Now, granted, the person who receives the kidney has to have a strong heart to pump blood through to help that kidney wake up. And you would likely need dialysis for 2 to 4 weeks following the transplant to help that kidney wake up. But again, our surgeons check to make sure that, they look at the big picture, everything, all the little parts in it, cause of death, age of the person. And if they feel that this kidney would wake up, they're going to use it. If not, they're not going to put it in you because it's not going to do you any good and it's not going to do the center any good.
Does a high PCH number preclude a transplant?
What is a high PCH? PTH, if you're thinking PTH, if you have a high PTH, we would make you temporarily inactive. And your dialysis unit would put you on medication to lower it. If the medication is ineffective, then you would be referred by your nephrologist for a parathyroid hormone or surgery. And they would take out 3 of the 4 parathyroid lobes that produce this. if the medication doesn't work. And I'm assuming that's what the PCH was, PTH.
If I have a living donor, which is not a blood match for me, but is still willing to donate, will I be guaranteed a match will be found?
These are phenomenal questions. With this one, if you have a living donor, and it depends on why they're not a match. Like if you're 100% sensitized and you have someone who wants to be a donor, but they're not a match because you have all those antibodies from pregnancies or blood transfusions, it might be longer to find you a match, but by going into the swap, we have access more. People who have living donors sometimes get, I know of a case where someone donated his kidney to a stranger so that his friend, who he wasn't a match for, got a voucher. So when he's ready for transplant, he will be the top person, and they look for the matches. So it all depends. The guarantee part, I can't guarantee anything with transplant, but if you have a donor who's not a blood match, the sole purpose of the living donor coordinator is to go in that, and you would be matched up. If they could find one, you would be flagged for that in that swap, in addition to the deceased donors. So you get both benefits. Does that make sense?
You're the kidney coordinator. Can a person be offered a kidney from a living donor, or is it only the case that someone might get a kidney from a living donor if they have a volunteer or are in a swap?
Absolutely not. Any person can get a living donor. I tell people, if you're shy, tell your friend with the largest mouth. If you're part of a church group, to have the minister announce it. Some of our people go out, and all a person has to do is they have to call the living donor hotline and say, hey, I'm Monica, obviously your name, and I want to be considered as a living donor for Marcia. And then they'll take the information, and they would call me, and they would play questions. So a person who wants to be a living donor can't have diabetes. They can't be overweight. There's certain things, but our nurse will screen them. They can tell you they want to be a donor, or they can do it privately. We keep things separate based on the donor. But for you to get a living donor, someone has to call and say they want to donate to you. And if they're a match, they don't need to go on a swap. If they're first checked to see if they're a match with who they want to donate to. The swaps are brought up if they're not a match.
They really do have good questions. Can you discuss the new way of reporting GFR? And
I love
also
these
discuss
questions.
COVID vaccines and donation?
Oh, I love these questions. You
I
guys are
know.
awesome. So the GFR used to be, and this was another way where, thank goodness, we're changing things. African Americans were at a higher risk of diabetes and high blood pressure. So up until recently, we had two eGFRs. African American, non-African American. One was always higher, one was always lower, which wasn't fair to either the African Americans or non-African Americans. And so we have been screaming for this for years, and it's finally become law, to where now it's just one GFR, and it's based off of your creatinine. There's a formula which is of benefit to all people across the board, because sometimes if you're African American and your African American eGFR was higher than the non, it wasn't really fair. So now it's just one number for everybody, which is across the board. And as far as the COVID vaccines and donation, right now I can say we're strongly suggesting and recommending COVID vaccines. We do not have a policy in place. It has been discussed. There are centers that have it discussed. We're not saying you have to, because it's not a policy, but based on what we've seen with the first year of COVID, we've learned a lot, but we also know the survival rate is much better if you have the antibodies from a COVID vaccine. I saw way too many deaths the first year of people who were transplanted who got COVID. It's just, and we are strongly recommending it both for the recipients as well as the donors. We don't have a policy in place right now. So it's a discussion, and it's a team decision. No one person surgeon or nurse are going to say one way or the other. We meet weekly with the entire team to discuss these different cases, and there's multiple factors involved.
I'm
So you're
O and they are B.
Usually would be the O first match. And it goes more down than just the blood type. There's more of a genetic breakdown. So I always say just have them call. And then what they do is they do the HLA testing, which is they break it down to your antigens and antibodies. It's much more than just the blood type. So I always say, you know, if you have someone who wants to be considered as a living donor, just have them call and let us do all the hard work. Don't worry about the blood type.
We also got a compliment that this was a great presentation. So
awesome.
We love to hear that. I've had a lung transplant several years ago. Does this impact my wait time in any way?
No, and unfortunately, it also doesn't help your wait time unless you're on dialysis. You know, the only way someone who's had a prior transplant gets extra time is if someone gets a transplant that fails in the first 30 days, they get all their old time back. If someone donates a kidney and then ends up needing a kidney themselves, they go to the top of the list. Having had another organ transplanted, especially lungs, doesn't necessarily follow. I know it does with liver. I don't believe it does with lung. I know we've just recently started seeing people with lungs, and I'm not 100% sure on that, but from my understanding, no, because it is a new area for us. I know it does with liver only within a certain span.
My father's nephrologist recommended he go through the transplant process at Hartford Hospital after he already did it at Yale and is on the list. Is there a benefit for doing it with both hospitals?
I say yes. I don't care where someone gets transplanted as long as they're transplanted. And I've also heard our medical director say the same thing. Obviously, you know, we would like someone to come to us, but no, we want you to get transplanted. And being the way that the organ offers come from distance and allocation, I've also seen where we might say different centers are more aggressive or more passive with surgeries, to where we might say hold off, they might say we'll do it, or vice versa. So I say absolutely, if your insurance allows you to be multi-listed, do it, but also be aware wherever you're transplanted, you need to follow up there for at least the first year. And the first 3 months you're seeing twice a week for 4 weeks, then once a week for 4 weeks, and then once every other week. So if driving and commuting is a challenge, you might not want to. If it's not an issue, I say go for it.
My father's nephrologist, oh, that's the same one. I'm sorry. Does when you get on the donor list determine how long it can take to get a deceased kidney? For instance, if someone who's been on the list 3 years versus someone who just got on, or is it determined by all other factors, match, age, dialysis, etc.?
Okay, I'm assuming you're saying when you get on the transplant list, not the donor list, just a transplant list.
Yeah.
So what qualifies your wait time is when you started dialysis. So if you've been on dialysis for 2 years and you're just now coming to be listed, you're going to have 2 years of wait time. If you're not on dialysis, it starts from when you're listed, proof for listing. What can give you extra time is if you have antibodies. So if you've had multiple children or blood transfusions, you could have antibodies. The higher the antibodies, the harder it could be to find a match. Therefore, you get extra points. So let's say you're 100% sensitized, which I could go one-on-one with someone over the phone later. That would make it much more challenging to find a match. However, definitely not impossible. You would be given 202 extra points, which is the equivalent of years. So if you have antibodies and we just list you and you're 100% sensitized, you're going to be at the top of every list until we find you an offer because you've got so many antibodies. Those are the only things that affect your wait time.
If the HLA is out of range, do you go into the inactive status?
So the HLA does not affect your status unless we don't have a current sample. There isn't necessarily an HLA out of range. HLA is basically just looking to see what your blood is made up of. It's like a bingo card. So we can match with the best match. If you have lupus, that can affect it. So we might want to get an extra sample in to do some more detailed tests. There's so many different tests our labs can do. Some are more accurate, some are more expensive. There's multiple things, but your HLA does not affect your status unless we haven't gotten a recent one in several months.
And we have someone who wants to know if you can be their transplant coordinator.
Oh, that's so funny. Thank you. I love what I do. And I used to do the whole alphabet. Then we hired someone where we split it. And we're actually going to format a new split, which will make it better for the patients, where I'll have less patients. However, I tell people they can call me, ask me questions, email me anytime. It's not a problem. I've been there the longest because I love what I do. But we're here for the patients, you know, and I'm helping my colleagues hopefully get to where I'm at so I can retire in 5 years. But that was sweet. Thank you.
Yeah. I thought that was really nice. I'm having fun with this too, because I can see names, and every time I look at a name, I go, oh, I remember talking to them, or I've gone through the list so many times too. So it's really great to see everybody here tonight. Did you say being on the dialysis affects wait time?
If you're on dialysis and you're not on the wait list, your time starts the day you start chronic dialysis.
Okay, I skipped one. Sorry. Did I hear you say that someone is did I hear you say that someone
who's
who is a
living
living
donor
donor will jump to the top of the list if they themselves ever end up needing an organ?
Yes,
Yes.
I have actually had two patients who donated a kidney to, one donated to their child and the other one to a friend. And the one who donated to the child ended up several years down the road needing a kidney. They went to the top of the list, got transplanted, and never needed dialysis, you know, because they get the extra points. The other person had received blood transfusion, so therefore had antibodies. So it was a little bit more challenging finding that person a kidney, but they did get a kidney. Unfortunately, they did do a short stint of dialysis, but because they were so generous in donating part of themselves, if they do in fact need one themselves down the road, they do get priority.
If my identical twin has high blood pressure, can she be a donor?
Depends on how much medication they're on. And also, as I mentioned, ethnicity plays into a lot of unfortunate predispositions. And I know that African Americans are at a higher risk for high blood pressure and or diabetes. So number of medications they're on. And if your twin is only on one medication and they happen to be a little bit larger, is it just because they're overweight that their blood pressure is high? So there's multiple factors involved, how many medications they're on, and other health issues. We have done things, you know, it does put them at higher risk of needing a kidney. However, it all depends on what's causing theirs.
When is the decision to have dialysis after surgery made?
So if you have one of those delayed graft function kidneys, the DGF for short, I say that because everyone says DGF and people go, what's that? And we anticipate, if it's a long time of cold time, and we anticipate it, we will just go ahead and start it. How we make that decision is we check your labs. We can sometimes the kidneys start perfusing right away after transplant. You start producing urine right away when you might not have been making urine for years. And or your labs, the creatinine should start coming down, the GFR should start coming down. So usually we do labs, you get your labs daily, if not twice a day in the immediate post-op period. And reflecting back to my days on the floor, we would get kidneys from the operating room on my floor. And so they do labs pre-op, during surgery, and then my 12-hour shift, we would be doing at least 2 more lab draws. So they're very closely monitoring your labs to see if that kidney is waking up or not. So you could need dialysis immediately within the first 2 days. Usually we'll know within the first 2 to 4 days if you're going to need some dialysis. And again, like I said, usually it's about 4 weeks at the most I've ever seen. Sometimes they wake up right away. Sometimes they take a little nudging.
We're out of questions.
Really?
Well, there are two in the Q&A, so I'll check that, see if they came over. Okay. Can you discuss the recent, we had that one. Are living donors specifically asked about swaps, or do they have to make an appointment to tell the living donor rep they're working with that date? Yeah.
Good question. So part of the living donor coordinator, so I'm going to use her by name, Grace. If you want to be a living donor, they would screen, and if you're not a match, then they would say to you, would you consider going into a swap? And then they would go down that road. Some people might want to do it sooner rather than later. But obviously, if someone steps forward, they want to be a donor for someone. We do have altruistic, it's happening more and more where people just come in and say, I want to give a kidney and I don't care to who, which is phenomenal. But majority of the people say, I want to be considered for so-and-so. And then if they're not a match, then they're addressed, would you consider a swap situation? Sometimes they say yes, sometimes they say no. It's completely up to them.
Any more questions? This has been, I think, the best patient program we've done. This has really been great. All the questions and the answers are excellent, of course. And Saskia, okay, hold on a second. We got some more. Fantastic from Saskia.
Yes, thank you.
Thank you, much appreciated from Tanya. Oh, look at all this. Terrific session. Thank you so much. This indeed has been a great session. Well done. Thank you very much, John Lavin. Awesome job. Thank you.
And again,
all.
you guys, you know how to reach me. If not, Marcia knows how to reach me.
Oh, yeah.
If I don't answer my phone, or my email, it's on my cards. Anytime questions, even if I'm not working. Unfortunately, I tend to check my phone a lot.
Oh, yes.
Well, I'm glad I was able to provide this information for you guys.
Yeah, it was really very interesting and very close to my heart, because I knew someone who didn't know to get back on the list after 2 years. He still was not. So anyway, this was very close to my heart. Oh, Connor, thank you, John. Thank you all very much, and have a wonderful evening. Good night, everyone.
Thank you.
Thank you, Monica.
Thank you, Marcia.